Hey everyone, it's Lieutenant Ryan Mitchell with the Pinellas Park Fire Department coming to you with April CME for 2020 from Pinellas County EMS and Fire. You'll notice that I am coming to you pre-recorded virtually from an undisclosed location, also known as my home, because I'm practicing good social distancing, social isolation. Pinellas County, safer at home, just trying to do the right thing to stem the flow and emergence of, you may have heard of it, COVID-19, coronavirus, the pandemic that we were experiencing. So we're going to go over some topics. You may hear some background noise. My lovely wife is also recording virtual content for her school children. So we're all working together, trying to get this done. And I'm going to hang out on this side of the screen. You guys hang out on the other. We'll keep our distance, but we're going to learn together and get through some good content. So let's do it. This month is going to be on pediatrics. So let's look at some objectives. Review the systematic approach to pediatrics. We're going to drill down on that. The pediatric assessment triangle, I'm sure you've heard of it. We're going to kind of peel back the onion a bit and get into that a little bit more in depth. Discuss the developmental stages of pediatrics, always a good one to review. Identify abuse and neglect in pediatrics, another added layer to a call that's low frequency, sometimes high risk, and then you add an extra layer of challenge. So we're going to talk about that, what you need to report mandatory wise, and always, if you've taken any class with me in person, I'm big on the mental health awareness, how to find resources. I always try and touch on it, and I'm a big believer in us doing it. So it's a salient point for us in this county, and truthfully, we've experienced it here, we've experienced it nationally, still a big deal, and we're on the very beginning of what will likely be a very challenging time for our whole profession, right? We're heading into a pandemic here in the U.S. and yesterday, I'm recording this now, yesterday we just surpassed China in known infection cases for COVID-19. So it's going to be probably a big issue for us, and mental health is going to be an absolute key in us being able to personally mitigate this within our profession. So we're going to talk about that as well. Let's move on. You get the call, you get the dispatch information, and utilize this systematic approach. Right from the get-go, you're already starting to develop your game plan with your crew, okay? So right off the bat, I hear some information coming in. I'm thinking, okay, what protocol am I going to pull from? If it sounds serious, who am I going to start chatting with in my crew, in the ambulance, in the rescue, in the fire truck, of, hey, listen, you grab airway, I'm going to grab the meds, this sounds legit, and just start kind of trying to figure out some roles and responsibilities. I have no shame in pulling up a protocol on the way to the call. I did it when I was on the rescue, and I just think it's a good idea. If you haven't run the call in a while, pull up the protocol, refresh your memory. There's no shame in that game, but get that picture together, start pushing out some concepts of who's going to do what, get that mental image of how this is going to roll out. Can things change? Always. Never, never, always. Listen, it's absolutely possible that it can change, but at least you have a game plan going in, thinking about what kind of equipment you're going to put together. And the hand heavy is based off of age, right? So if you have an age, you can already start thinking, okay, what page am I going to pull from in my hand heavy book? Once you get through that dispatch information, scene is safe, you walk up and you start getting a general impression based on what you're seeing walking into the room. And we utilize the pediatric assessment triangle. We'll talk about that a little more in depth to get a doorway survey, okay? So you get a doorway survey based on a few parameters that we'll talk about with the pediatric assessment triangle, and it allows you to define, is this a patient that I can stick around with, work with, talk to the mom, or is this a patient that is legitimately serious? We need to get going and get them to a higher level of care at the hospital. So we'll talk about how that rolls out. After my pediatric assessment triangle, I'm going to rock right into my primary assessment. You'll notice that there's an added letter there. You've seen it a couple of times. The X, exsanguination. It's trying to control hemorrhage. So right off the bat, you're going to try and mitigate any hemorrhage that you see in that patient. And that goes for pediatrics or adults. Think about it. I can go right to my airway. I can lock down that airway. I can start oxygenating, dumping that oxygen molecule, loading that red blood cell, doing all these awesome things. But if I'm just doing that with blood that is pumping out of the concrete, I'm really just oxygenating the concrete. So I want to stop that bleeding so that any procedure I do after that actually stays within the case, the body that I'm actually trying to save, trying to work with. So stop that bleeding. Just take note, it's an extra added letter onto the ABCDE mnemonic there. I want you to take a look at exposure down here as well, because it's one of those, if we don't do it, we're likely to miss something that could be pretty significant to our patient's condition. Obviously in our trauma victims, pediatric, adult, doesn't matter. We're going to expose them. We're going to make sure that we see all those injuries, because I tell you, working from the hospital side, there was a lot of things that I saw come in that I was like, man, if that was me on the field, I could have made the same mistake, and I probably have made the same mistake of not noticing an injury because I didn't do the full exposure earlier in my career. I definitely try and do it now. I know it's a pediatric patient. I know that can add some discomfort to the process here, but you have to expose them. You know, and in medical patients, you know, do you really want to be the one that missed a whole bunch of hives all over your child's stomach? That might have been explanatory of their respiratory distress. Take a look at these kids and make sure that you expose them in a way that suffices a more complete primary assessment on these patients. You know, put it in your toolbox and it'll help. The pediatric assessment triangle. You have three sides to it: appearance, worker breathing, and circulation. If any one of those is off, it really gives you an indicator that we need to make this a quick patient. We need to do whatever immediate care we can and then get off the scene. If we don't have any of these triggered, then we can kind of take a little bit more of a prolonged approach, a little more detailed approach, I should say, on scene. So let's get into the pediatric assessment triangle and see what things trigger these sides of the triangle. So right off the bat, this is a general impression tool. It's giving you the initial picture of the underlying cardiopulmonary status, level of consciousness, right? So if I walk in and I see a pale kid who's lethargic, right? Their appearance to me looks like there may be a compensatory mechanism going on. There may be a circulation issue going on. They're breathing super fast. Right off the bat, I'm getting the initial underlying picture that this patient is a quick patient and I need to go. Quick versus not quick. You see it there on the PowerPoint right here. This does not replace a primary assessment. You're still going to roll into that, but it gives you that initial survey. It's kind of like your windshield survey for trauma. This is your doorway impression, walking right into the home of the patient, getting an idea of what we're going to do. And it helps you right before you reach the patient's side, so you can already start thinking, as soon as I get there, I'm going to rock and roll and start getting things done that I need to get done. So let's talk about appearance. It's one of the most important in determining the severity or illness of the injury and the need for treatment. It reflects a whole ton of things. Look at these. I mean, these are integral parts of things that you would want to treat, right? And it helps utilizing the Tickles mnemonic: tone, interactiveness, consolability, look, gaze, speech, cry. If I walk into a room and I have a kid that is lethargic, not really responding to me very well, and I'm a foreign person in their home coming up to them and they don't really care, right off the bat, I'm already getting a sense that this child is probably pretty sick and needs to get to a higher level of care, right? I'm way more comfortable with a kid that is crying, looking at me, grasping. I don't love hearing children cry, and nobody does, but if I hear a child crying and doing all those active things, that's giving me an idea that this kid is at least well enough to do those things. The other side of this is if you have a kid that is not consolable, right? Just crying, consistent pitch, just keeps going. It's the only tool that child may have to tell you that something's really wrong. So there's kind of like two various sides: really lethargic or inconsolable, and pale would be another thing that you're going to throw into the mix here. But it's giving you that general impression. Some of those tools that'll allow you to make that decision: am I going to stay or am I going to go? So the work of breathing, you get through the appearance is good, but you start looking at the work of breathing, and sure enough, you see the child breathing super fast or super slow. I mean, we've been in the field long enough, we can kind of have an idea of what that would look like. Intercostal retractions, work of breathing, or the work of breathing has gone on so long that now you see a severe lack of work of breathing, right? It's giving you an idea of the effectiveness of gas exchange. Pediatric patients consistently start with the imminent issue being a respiratory issue. So work of breathing is a pretty important part in identifying how this is going to roll out and what issues are going on. Respiratory system is a major buffer. You're going to do a lot of things respiratory-wise to compensate for something going on in the body. Acidotic, alcohol, there's a whole bunch of things. We'll talk about it, but this is a big part in identifying, should I stay or should I go with this patient? You don't necessarily need a stethoscope for this, right? You can look at the patient. I can see intercostal retractions. It may mean lifting up the shirt, just taking a look once you get there, but having an idea, general impression when you actually get there really helps. Circulation. This is one of those things that we've gone through work of breathing. The appearance generally was okay. The kids seemed like they were tracking me. Didn't look too off, but once I've gotten up there, and I've gotten a little closer to look at the patient. They're looking a little pale. I see a little mottling, a little cyanosis. Maybe, depending on the skin color, I might look at the mucosal membranes. But I've assessed at this point that there's an issue with circulation, meaning that if you have a child that's pale, right? Why would the child be pale? They've shunted blood from the skin, this large organ that covers our whole body. They've shunted blood away from the periphery and away from the skin because your body, your neurologic signal to your body has said, hey, listen, something bad is happening here and I want to compensate for it by pulling blood from that organ, the skin, to the major organs, heart, lung, brain, liver. I want to perfuse those things over necessarily perfusing the skin. It's pulling our available resources to really fight off something, right? So a pale child, a child who's cyanotic, not perfusing oxygenated blood as they should, is a huge indication that we've already gone through the work of breathing issue and now we're maybe at circulation and there's a circulation issue. Gives us an idea of what we may be dealing with. And is it a quick or not quick patient if you see some of these red flag symptoms in circulation? Absolutely. Quick patient, get them out of there and start, getting to a higher level of care. So you've heard me say quick versus not quick, right? When any one side of the triangle is affected, they are a quick. It helps determine a lot of things. You see right here, respiratory distress, respiratory failure, impending respiratory arrest. Again, we're concentrating a little bit more on the respiratory impetus for these patients because pediatric patients often start with a respiratory issue that progresses after that. A lot of adult patients, cardiac disease is one of the leading killers of adults. Pediatrics, it's usually a respiratory impetus. Trauma is also one that we can throw in there. So let's talk about some of the respiratory issues and how they kind of roll out with our quick patients. So respiratory distress. You walk up, the kid's got a normal appearance, they're tracking you, they seem like they're aware, maybe they're a little scared of you. That's actually a good thing. It's a good thing that they have that emotional capability to not necessarily want to be around a stranger that walked into their room. Right, so you've got some good normal appearance, but you notice the kid has increased work of breathing. We're going to put them into the respiratory distress category. Their skin color is normal, cap refill's good, you don't notice pallor, they're not mottled, you know that the body hasn't gotten to the point where it said, hey listen, throw the kitchen sink at this, shunt blood to the core. Your skin color is good. It's still a quick patient because you have an increased work of breathing, and we're probably on the front end of this compensatory mechanism, and for children, they compensate, and then drop, right? So we want to get this on the front end. This is a front end tool that's telling us, hey, we need to probably get out of here with this patient. It doesn't mean sacrifice care, but it means start providing care and get moving. So respiratory failure. Increased work of breathing has been going on so long that now your child is beginning to become lethargic. They've been working so long that we're compensating. We're starting to reach the top of that curve where things are starting to spiral down. The child's getting really wore out from that increased work of breathing. This is a telltale sign that this is a sick kid. They should not be lethargic in the middle of the day. They shouldn't necessarily be totally wiped out when you have the stranger walking in the room with all this gear looking, different than what they're used to. They're fatigued. You still have normal skin color because you haven't gotten to the point where the body's throwing the kitchen sink yet at this issue yet. But this is, again, quick patient, get them out of there and get moving. Don't sacrifice care, but get them moving. Respiratory failure. So I'm gonna sit along with you and watch this video of respiratory failure. It's a really good example of it, and I think you guys will get a lot from actually seeing this in play if you haven't seen it before. And if you have seen it before, it's a good reminder of this is something that we need to move on. So let's take a look. I'm gonna put on my headphones and watch along with you. Cool.
Alright, this little guy actually presents here. He's a non-insulin-dependent diabetic, and he's come in with a pH of like 6.9. He's actually got a little bit of a probably a dental abscess that's kind of kicked him off here, but his breathing is really what we kind of call Kuzmar breathing, and when you smell his breath, it basically has a very sweet kind of a acetone, ketone sort of odor to it. So he's getting his getting a little fluid bolus of 20 per kilo, and then we're going to also give starting at 0.1 units per kilogram per hour of insulin, and he's going up to the intensive care unit. And his here, his initial, like I said, his initial pH was 6.9 in that ballpark. So his mom knows these videos end up on YouTube, and she's okay with that, right, Mama?
Yes.
Okay, all right, good. Anything else? So basically, when he went to bed last night, his sugar was what? 99. Yeah. And then when he woke up this morning, he had a little trouble waking him up, and he was breathing like this, right? When was he diagnosed with diabetes? Okay, 3 years old. Okay, so he's 5 now. Okay, and is this the second time he presented with breathing like this, or has he ever? You've never seen this before. Okay, so this is the first time. So, all right. Well, thank you so much for letting us do this, because I think this is important for people to see what is Coues multi-breathing and how someone with diabetic ketoacidosis would present. So, thank you so much.
Okay, so you guys telling me, is that a quick or not quick patient? I mean, all day. This is a lethargic patient. You see the increased work of breathing. And again, the respiratory system is a major buffer. So he said this child was acidotic, diabetic ketoacidosis. The buffer of this child's system, the respiratory buffer, is trying to blow off some of that CO2, and has worked for such a long period of time. And now he started to go into this aberrant Coues-Mal breathing, and has become super lethargic, is basically ineffectively oxygenating at this point. And what are they going to do? They're going to get insulin on board, 20 cc per kilo of fluid. They have other levels of care that we can start providing in the field, but that they have in the hospital that they can kind of up the game on. So definitely a quick patient, awesome example of it. So keep it in mind what that looked like, and if you walk in a room seeing a child like that with your pediatric assessment triangle, you know what you got. You got a quick patient, you need to rock and roll. So let's take a look here and move on to impending respiratory arrest. You've got all things marked off. Poor appearance. The kid is not tracking you, very lethargic, work of breathing. They've consistently worked so hard that now they're on the other side of that curve, and now they're starting to go down with a decreased work of breathing because they don't have the compensatory mechanisms to even compensate anymore. Poor skin color, they're pale, they've thrown the kitchen sink in this, they've shunted blood to the core, likely probably starting to get hypoxic because they're not bringing in enough oxygen molecules to sustain the tissue's need for oxygen. We've got a whole bunch of things going on. Are you going to stay or are you going to go? You're going to rock and roll this patient. It's going to be a quick patient, and it does not mean delay care, but it means getting your care going and moving. So we got our developmental stages. Take a look at them. I've got 5 developmental stages. I'm not going to read it to you, but your treatment and assessment may differ depending on the age and development of the child. So let's take a look at that a little more in depth and see how our care might change. Neonate to infant. Your neonate, first month of life, infant is less than 1 year, and they don't do much more than eat, sleep, cry, and maybe do some other things that cost you a lot of laundry or a lot of money in diapers. So eat, sleep, cry, and then they're beginning to jettison on a regular basis, and it's a lot of workload for the family, but pretty joyous time because you got a new kid in the world. So 2 to 6 months, they become a little bit more active, start recognizing caregivers, they track a little bit better, their eyes are opening a little bit more at that time. 4 months old, they can actually hold up their head, and then 6 to 12, they can sit unsupported. This is a super exciting time because they become a little bit more mobile and a little bit harder to catch. 9 months, they start developing not only a recognition of the caregiver at this point, but now kind of a recognition of this is a different person and I have a little bit of anxiety to this new person coming in the room. How does this affect our care? You got to be opportunistic with your exam. Now think about that. What would that actually mean? Opportunistic with your exam? Take what you can get, right? If I can slide my hand up on the brachial and grab a brachial pulse, awesome. But I'm going to try and base my care on what the child's going to allow me to give without causing too much distress. Work with the mom, work with the dad, work with the caregiver to try and basically facilitate care. Warm your hands on the stethoscope, just don't put like a super cold stethoscope on there. Jingling keys and trying to give a distraction so that you can do something while they're tracking something else. Awesome idea. You know, you can start getting into, is there a change in behavior, feeding, sleep pattern, some tip-offs that there might be an underlying illness. We now know that those changes in responsiveness with your child actually indicate probably a very high likelihood of a possible issue that needs to be treated in a medical facility. So rely on your parents and see if there was a change there that might tip you off to something more serious. Toddlers. Okay, this is where parenting becomes even more busy. Right, you got 1 to 3 years of age, behavior changes from dependence to getting a little bit more independent from the caregiver. They're starting to run away, you're having to run after them. Not necessarily capable of reasoning at this point, but they are also beginning to have some negative associations with healthcare providers because this is a different person. Independent from their personal caregiver, but still kind of skeptical of new people coming in. Toddler assessment keys. So basically we can get into the pediatric assessment triangle. We can explain, not reason, but explain, hey, I'm going to put a blood pressure graph on your arm. It's going to give your arm a hug. We're going to assess them in the caregiver's lap where they're a little bit more comfortable. Again, they're having some discomfort with new people in the room generally at this time period. We can check for vocalizations, how's their mobility, utilize the parents and the caregivers as a tool to see what's different. But you have some different development here where there's a little bit more independence and you can work with your patient a little bit more, utilizing the parents as a tool to provide comfort. If it's a non-quick patient, start toe to head. Allow them to be in the caregiver's arms, caregiver's lap, and then you can kind of introduce your presence to them toe to head. If it's a quick patient, hey, listen, outside of exanguation, I'm going to go right to the head and start down for my airway and move on through a quick assessment and treatment based on those findings. That doesn't change, but if it's not a quick patient, I can go toe to head and ease this child into the reality that I'm in their presence, right? Preschool age children, 3 to 6 years old, they begin to start understanding direction. They're a little more engaged in the activity. You can explain to them a bit more of what's actually going on. They can talk back to you in a little bit more of a story narrative style, and you can use plain language and reassurance to interact with these patients. Your preschool age children, years where you can actually communicate a little bit with them, utilizing their own ability to shape story and narrative about what they're feeling, and you can explain back to them a little bit about what you're going to do. Avoid yes or no questions. Allow them to kind of tell you what's going on, and then give them some independence to look at your equipment, look at your gear. They have that innate curiosity. Use it as a tool. Their desire to cooperate. So you can also they're still looking at you as an authority figure to some degree, so you can set some limits on behavior. If they're slapping their brother in the face, hey, listen, we're not going to do that, but hey, how about looking at my stethoscope? How cool is that? You're not quick patient, toe to head to toe. It really depends on the relationship that you can tell that exists between you and the patient, right? Read the room, see how the kid's interacting to you. If they're a quick patient, bread and butter, head to toe. Don't need to go over that again. Your school-age children, 6 to 12 years old, a lot more capable of reasoning. This is when they start kind of challenging you on topics as a parent, and expect that they're going to probably do the same thing with you as a new caregiver. They can tell you stories about their illness or injury. They understand cause and effect. There's a little bit more reasoning going on, and their anatomy is a little bit more similar to that of an adult. So moving into their assessment, they can give you a little bit more history about the illness injury. They can probably tell you what's going on. Still using some plain, simple language. Allow the child to describe what's going on versus the parent. The parent may want to tell you everything, but see if you can get the story from the child, because they may actually be able to give it to you in a little bit more clearer terms because they were probably actually there, right? Because of that kind of reasoning framework, you're able to provide some ongoing reassurance, encouragement. Whether they're quick or not quick, do your head to toe, because again, you're able to kind of build a little bit easier rapport with these children in this age group. All right, let's talk adolescents. So 13 to 18 years old. Take a look at this list. As adults, are any of us dealing with these things as well? Yeah, absolutely, right? So they're dealing with a common foundational framework that adults are dealing with, right? They've pulled away from parents to some degree and are identifying friends as key support figures. So you might be able to use the friends as liaisons to communicate with them. And this is a time for experimentation and risk-taking behavior, right? They're getting out into the wild world and they're doing some crazy stuff. I mean, for me, I broke my right ankle 4 times, my left ankle 3 times, and broke my arm and my fingers. I was a wild kid. If you're in the fire service or EMS, we're probably wired to be pretty active and wild. So think about how you were 13, 18 years old and imagine the injury modalities that can occur here with that risk-taking behavior. Probably a little bit more emphasis on trauma in this age group. Key assessment factors: treat them as an adult in respects to assessment. Talk to them and respect them enough to explain what's going on and have that conversation, build that rapport, and address them. They may want to tell you a little bit more on their own versus in the care or company of their parent, right? Allow them some privacy during the narrative part of your exam or the physical part of your exam. You know, they may be a little bit more open to talking to you on their own, especially if it's something sensitive about sexuality or drug use, right? They're getting into that risk-taking behavior and they may not want to talk very openly about that with the caregiver or parent. Treat them a little bit more like adults and give them that respect, because you know it's a good chance they'll give you the same respect back. So pediatrics, low frequency, possibly high risk call, so challenging call right from the get-go, and then we add an extra layer of pediatric abuse, something that's very challenging to deal with emotionally for us as caregivers and to experience, and it just adds a lot more complexity to this call, so we have to talk about it. Physical pediatric abuse, it's intentional, results in death, disfigurement, or distress. Emotional, it interferes with the normal psychological and social development. This isn't just an acute event. It's something that didn't come and go. It's something that's actually engaging long-term change in your pediatric patient. You know, our sexual abuse here, developmentally immature child, adolescent, dependent for an older person's sexual excitement. These are really challenging topics. It's not fun to talk about, but it's necessary. Neglect. It's a little less overt than the actual abuse that we just talked about. It has some passive aspects to it, and it's just a failure to supply necessities or engaging in child-rearing practices. Ultimately inadequate or dangerous to that pediatric patient because of that neglect, because of that failed supply of necessities, right? And we can look at a couple of types here, right? We didn't meet the child's basic needs, whether it was supervision, housing, clothing. And this is where you, as a liaison into this environment, can now kind of start putting together some pieces. This does not seem right. This kid is not taken care of. The parent is not engaging with them like they should. The child's walking off and climbing into an open oven. Like, we can connect some dots here and say, well, listen, this child is not interacting with the parent like they should. The parent doesn't really seem to care that this child is scaling this bookcase, that is walking out in traffic. The child doesn't have clothes, doesn't have shoes, is dirty, has clearly been denied medical attention for an extended period of time, is malnutrition. The emotional failure to support affection necessary to a child's psychological and social development. These kind of children that are exposed to this, you'll notice that they are acting young for their age. Some of the vocalizations even last into adulthood, where the people speak or sound similar to the age in which the trauma occurred, right? So their voice like stays at that age, even though they've progressed physiologically in an older direction past that point. So it really has some detrimental effects. So whether it's overt abuse or passive neglect, still carries a lot of weight with regards to your pediatric patient, and we can be the voice for people that might not have been able to voice it on their own. So how can we be that liaison, that voice of the child? Well, we can maintain situational awareness. The information not just come to us from the parent or the child. We may be able to look around our area and the environment that we're in and make some assessments of what we're seeing. Look at some of the caregivers' behavior, right? They might not tell you, hey, yeah, I've been abusing my child. They probably won't, but you can look at some of these common characteristics. Drug use, I've definitely run a ton of calls where we walk in and the parent is inebriated, is not responsive because they succumbed to some sort of recreational drug, and the child's wandering around. I mean, this is like right out of the gate a red flag that there is obvious neglect or abuse going on here. Take a look at your scene. What is around the child? Are there sharp objects laying out? Is there the child have access to a shotgun laying next to their bed? Is there a padlock on the outside of the door? I mean, I don't know, but we run into these really challenging environments, and just please maintain a high level of situational awareness of things that you would think would be pretty odd if they existed in your childhood or your child's life, right? You can be the ambassador and the voice of reason in this and maybe help somebody out. Red flags, caregivers' behavior, apathy, bizarre, strange conduct. They lash out at the child really hard. And it really seems out of context for why they would be lashing out at the child. They're drunk, they're intoxicated, they're not forthcoming with the events. You've got, injury pattern that's of varying degrees of age, bruises varying degrees of age, and they said, oh, well, they just fell into a doorknob. I mean, why do I have bruises all over my body, all over my patient's body from that? It's not rocket science, but have the strength to look at these things and pass it up the line and be that voice. Does the story or history of the child's condition change over time? Are there, like we said, multiple injuries of multiple ages? Do the injuries fit the history? Why would I have abrasions or burns when I fell into a doorknob? It doesn't really make sense. So really putting together that encapsulated picture and seeing, are there faults or cracks in the image that I'm being given here? 90% of maltreatment victims have some kind of injury. So what does that mean? It means that we need to actually take a look at our patient, and do a full engaged assessment on this patient. We're looking for bruises, burns, fractures, deceptive skin signs masquerading as abuse, right? Oh, they have just a broken arm. Why do they have a broken arm? What were they doing? Maybe they didn't just fall. Maybe there's some other things you can connect the dots on to identify why this injury occurred. And it's not just a normal kid injury. This may be something akin to abuse. Just anything unusual, put it on your radar. As you're talking, how did the injury occur? Is there a plausible explanation? When did it happen? Did they delay calling 911? Is this an old injury, or did they leave it for a while? Why would they do that? Were they questioning whether or not they wanted these authority figures in their home because they knew that we might have a heads up that this is possible abuse, right? Who witnessed the event? Was there adequate supervision? Did they let their kid just, run out into the street unsupervised? All these things. Just take a look here, take a second, and I'm not going to read the slide to you. Get familiar with some of these things, right? Do they actually have a physician? That's a pretty good one. Are they 6 years old and they've never been to a doctor and they don't have a physician? Kind of strange, right? Based on all these findings, we started to put together this picture, and I'm just going to read the underlined red print here for you guys because it's really important, and there's no real way to get around understanding. This is in our protocol CS8, mandatory state reporting requirements. So you see some of these things. This is how it qualifies and plays into what we need to report. Any person who knows or has reasonable cause to suspect that a child is abused, abandoned, or neglected. That's us, right? So we are that any person, and we may actually be able to affect some change here because now we're in this environment and we may be able to be that liaison. We'll look down here at the bottom. Any person who knows or has reasonable cause to suspect that a child is a victim of childhood sexual abuse or is the victim of a known or suspected juvenile sex offender, we have to report it, right? So mandatory reporting requirements. You think you've seen this, you have to report it. We are the anyone in this person, the any person, and we need to pass up the line. So what does it mean? We've identified these things. What do we have to do as far as reporting? We need to fully document in our PCR, our patient care report. We need to notify the Florida Department of Children and Families. They've actually got a link built right into the mom's manual here. Notify the appropriate law enforcement agencies and notify the receiving hospital personnel. Probably pull your supervisors in on this and let them know what's going on, and as a group, navigate this in the best way possible so that it's reported correctly and the correct care gets to the child. That's the whole point of this, is that we do the best for a child and we can report it in a way that it actually gets acted upon. There's a thing in here that I think is good to note with regards to burns, and I can't tell you that I was 100% familiar with this, so it was really good for me reading over it, and I want to make sure that you guys are on the same page just like I am. Any person who initially treats or is requested, us, To treat a person with second-degree or third-degree burn injuries affecting 10% or more of the surface area of his or her body shall immediately report such treatment to the local sheriff's department if the treating person determines that the burns were caused by a flammable substance, and if the treating person suspects the injury is a result of violence or unlawful activity. So I just want to clarify with these two sentences. There is determines that the burns were caused by a flammable substance, and if the person suspects injury as a result of violence or unlawful activity, right? So it's the and that kind of connects those. If you feel those are connected, you know, run it up the line and make sure it's reported. I didn't fully understand that, so I wanted to make sure you guys did, and I'm glad it's in the PowerPoint so we can all get on the same page about it. We can all learn. I'm always learning, and so can you. Again, you're going to fully document the situation and observations in the PCR, and then you're going to notify Pinellas County Sheriff's Office. I would probably also pull your supervisor in on the mix and let them know what's going on. I appreciate you guys being here. We definitely are moving into a challenging time with this emerging pandemic, and I just want to tell you that I appreciate you taking the time to actually try and learn. Hopefully this is a bit of a distraction from all the stuff going on, and I appreciate you taking the time to pull away from all the COVID-19 coronavirus news briefs and ticking stock tickers on the news and all the stuff that we're seeing, all these inputs, and focus in on something that, you know, amidst this whole pandemic, we have patients that may be suffering from things other than COVID-19 and coronavirus, and it's really good to talk about it, especially with regards to pediatrics. It's just one of those things that we, you know, low frequency, possibly high risk, something that we don't deal with all that often, and I think, you know, I'm happy to review it myself. I feel good to go over it and get it locked back in my head, and I hope that you got something from it. If you have any questions, you see me out on the road, ask me. If I don't know, I will try and find out. If you have questions and you don't see me, send them up the line, and just check in with us and let us know what we can better do to facilitate this information. It's good stuff, and I appreciate you doing it with me. Take care, and I'll see you out there.